everybody. Thank you so much for coming today and for your patience while we set up the AV. And I'm Lindsay. I'm the events coordinator for LACNETS. As some of you may know, Giovanna is actually in Germany right now receiving the PRT treatment, and she sends her best. She was trying to send a voice recording of her to wish us the best meeting today, but unfortunately technology is complicated sometimes, and it wasn't sending. So she sends her best, and she wishes she could be here, and of course we send her our best as well. So just one announcement before I introduce today's speaker. Our next meeting is going to be here the second Tuesday of the month as usual, same time, same place, 11 a.m. to 1 p.m. on October 11th. And so the topic and speaker is still pending, but you'll be receiving a newsletter shortly with all the details with the next speaker. And so now I'm very excited to announce today's speaker, Dr. Matthias Eiber. A little background on him before he comes up. From 2007 to 2012, Dr. Eiber was resident at the Institute of Radiology in Munich, with rotations to the PET Center at the Department of Nuclear Medicine and to the Department of Neuroradiology. Since 2012, Dr. Eiber has been a board-certified radiologist. In 2015, Dr. Eiber became a board-certified nuclear medicine physician and an attending physician at the Department of Nuclear Medicine responsible for section PET imaging. Dr. Eiber has also published a range of research papers within his field of expertise. Today, he is a visiting assistant professor at the Department of Molecular and Medical Pharmacology at UCLA. And so before I introduce him, I just want to remind you guys we have a Q&A following his presentation, and it's going to be video recorded, so please keep any personal questions for when the cameras are turned off. We'll have a chance to ask personal questions, but while the cameras are turned on, please keep the questions general and not personal. So without further ado, I'd like to welcome Dr. Matthias Eiber.
Thank you very much, Lindsay, for the kind introduction. Welcome, everybody. My topic today in this meeting is entitled Somatostatin Receptor Imaging and Therapy Neuroendocrine Tumors, Current Status and Developments. And indeed, there are some important changes in the landscape of neuroendocrine tumor imaging and treatment in the last few months. And this I will tell you today. The topics I will cover in my talk is, in the beginning very shortly, introducing the target and the mechanism of imaging and therapy in neuroendocrine tumor. Then the question, where are we now with gallium dotatate imaging in the United States? And then I think also a question some people might have today is, what about treatments, or what about PRT these days in the United States? And finally, I would like just to introduce the UCLA NET team. So let's start with background on somatostatin receptor. So there is a rising incidence in neuroendocrine tumors, and neuroendocrine tumors are usually very well differentiated tumors, and they mainly express the so-called somatostatin receptor type 2 at the surface of the tumor cells. And this is basically the ideal or the principal target for the imaging and for the treatment compounds. So how does an imaging or a treatment compound look like in general? So it's basically it's a little bit like playing Legos at home. So you have to have a target with a specific target work. So on the left side you have the target. In the case of endocrine tumor, it's the somatostatin receptor type 2. And then on the right side you have the imaging or the therapeutic agent. And to bring this imaging or therapeutic agents to the right target, you have to design a so-called ligand, which is the key, which should perfectly fit in the target, meaning into the lock. And adjacent or attached to this ligand is, via a so-called linker, the radionuclide, or the imaging or the therapeutic agent. For somatostatin receptor type 2, this is the target. The octeotide is the ligand, and the octeotide is relatively constant when you look on different imaging agent. But what can be different is the so-called chelator, or also called linker. So the piece of the whole peptide which is used to link the ligand and the nuclide. And on this chelator you can bind either, for example, gallium, which is an imaging agent. So gallium is a beta positron emitter, so a beta plus emitter, and this can be used for PET imaging, so for positron emission tomography. And besides gallium for imaging, on this linker you can also couple lutetium, for example lutetium 177, and this is a therapeutic agent. So this is a beta emitter which can be used to treat tumors, and I will come to this a little bit later, but I think it's important to understand the principle of a specific target, in the case of neuroendocrine tumor, the somatostatin receptor 2, and that you have to have a ligand which perfectly fits as a key into this lock, and then on this key you can attach other things, for example for imaging or for treatment. Why is the imaging agent called DOTA-TATE? Because of this TATE or DOTA chelator together with the last a part of the octeotide name. So how does this look if we go to the level of a cell? So this is the tumor cell membrane here shown in gray, and on the tumor cell membrane neuroendocrine tumors have different surface proteins. So the somatostatin receptor type 1, 2, 3, 4 and 5. We don't need all of them, we just need the one who is most relevant as it has the highest overexpression, and this is the somatostatin receptor type 2. This imaging and therapeutic agents, they also address other types, so the type 4 and 5, but this is not so relevant compared to the type 2 for the imaging and the treatment. And then any of these ligands shown here on the left side, they bind to this surface protein, so to the receptor, and then they get internalized, and you see this here. There is an internalization of the peptide, and then it gets stuck into the cell, and this is the mechanism why these ligands, both for imaging and therapy, they accumulate into the cells, which give you a high contrast in imaging and a high therapeutic effect in therapy. So how does a so-called PET, so positron emission tomography image using DOTA-TATE, or now commercially available also called Netspot, how does this look like? So what you have to take in mind, that there's a physiological distribution of the somatostatin receptors in the body, so not everything we see here on this left image is related to neuroendocrine tumors. You see a physiological uptake, for example, in the liver or in the spleen and also in the kidneys, and the tracer or the peptide is excreted via the urine, so you see a lot of accumulation in the urine. So this is the normal physiological uptake, or the physiological distribution pattern, how we call it. And then other sites, which are, for example, here marked with an arrow, are sites of tumor involvement in this patient. And what you see here is the very high contrast between, for example, this region here, it's the region of the right thigh. You see nearly no background, and you see a relatively high uptake in the tumor lesion. The same is valid, for example, for this lesion here, which is located in the chest, which represents an mediastinal lymph node, and there's also another lesion, and you can see this here, for example, on this axial slices. So axial slices in imaging always means the patient is sliced in this direction, and you look on the patient from his feet. So the left side of the patient is right in image and the right side is left in image. And what you see, for example, here is a slice in the region of the lungs. So you see here this these black areas are the lungs, and these are the big vessels in the chest. And you see here, for example, a lesion in the bone, and here another lesion in the bone a little bit deeper. And then, for example, here there's also a lesion in the bone, and this corresponds to this lesion here. So I don't know how many of you already had a Octeotide PET, because then sometimes, and I think this is relevant to know, you can read something called SUV as abbreviation, or standardized uptake value. And what is this? This is a value we can get from a quantitative PET image, which directly reflects the somatostatin receptor expression. So knowing whether this value is high or low, we can also, with regard to therapy, make predictions whether there's a good therapeutic effect or not. So high somatostatin receptor is always a very good indicator for a good therapy response, because you have a high target expression. So the somatostatin receptor is very high expressed, and then when you do treatment, I come to this later, then you also get a lot of molecules to these areas where you have this high target expression. One thing, unfortunately, is a little bit cut out here on the big screen, is what you might also read in a report is the so-called TBR, or tumor background ratio, and this describes how hot is the tumor compared to the surrounding tissue, and this can also give you a value, and we use this sometimes for lesions in the liver, because in the liver, as you can see here, anyway the uptake can be very high. I show you then in the next slide a patient with a liver lesion, and especially for the liver it's very important to look whether a lesion or whether multiple lesions have a higher uptake than the normal lesion, because this is roughly the cut-off which we set whether it's worth to treat a patient then with radioactive medication, or whether probably something else is more useful. So before I explaining you the differences between the old Octeotide scan and the PET scan, I just would briefly explain here things concerning the liver. You see here now the liver is not so bright anymore, and this is related to the fact that you can change the level and the width when imaging or when reviewing images of a patient. And what you see here clearly, there is a lesion which has a higher uptake, we call it, so an accumulation of the radioactive peptide than the surrounding liver. So this would in principle be a good indicator or a good basis for a radioactive treatment. It has been shown in numerous studies that the Octeotide neuroendocrine PET imaging agent is superior to other methods, for example, cross-sectional imaging, and this you see, for example, here, because this liver, okay, this is a CT without contrast, but nevertheless this lesion cannot be appreciated on the CT, but can be appreciated on the PET. And there is this relatively old method of Octeotide scintigraphy. This is, I think, out for now more than 20 years. It uses in principle the same basis as the PET agent. So a key to a lock, and then a radionuclide, which in this case is indium 111. But what you see here, comparing the images of the these two images in one patient, you see that with the Octeotide scan there is a less spatial resolution, and there's also a less intense tumor to background ratio. So some of the lesions we see on the right side, for example, this lesion here unfortunately cannot be appreciated in the Octeotide scan. And I'm sure that some of you already had Octeotide scans and probably are thinking potentially getting an Octeotide PET scan. And this is also one thing I would like to mention or would like to emphasize. When we see more lesions on the Octeotide scan compared to an Octeotide scan, which might be like 1 or 2 years in the past, that does not necessarily mean that in the meanwhile new tumor lesions have developed, because as you see on this image here, the sensitivity of the Octeotide is so much higher than the Octeotide scan, so we cannot just tell whether we now see the lesions which have been there before or whether these are new lesions. So it's always not a good idea to directly compare the two scans. It makes sense to have, in certain instances, a Octeotide scan to see what is the current status. But if you then want to look whether there is stable disease or whether there is not stable disease, it's necessary to get in a certain amount of time another Octeotide scan and then compare the old Octeotide with the new Octeotide, and not compare the Octeotide with the Octeotide, because this can only cause trouble, because you don't know whether it's really a new or whether it's just old lesions we only haven't seen in the Octeotide scan. So one thing I would like shortly to cover is the impact of on management. And I think some of you know that the Octeotide, the gallium Octeotide imaging agent was recently FDA approved and is also available now via AAA. And one of the preconditions always necessary for a new drug application or for a final drug approval is our studies showing that this imaging agent really makes an impact on patient management. It's just that we have a nice image of a patient, but also that it has a clinical consequence for the patient. So there are some studies out dealing with this, and probably some of you have already been at UCLA having an Octeotide scan, and then probably you know that you had to sign some documents, because we are also doing a study on the impact of management, and that was also the requirement our institutional review board had, so that it got us the application of the Octeotide PET agent approved. So very shortly, the impact of management design at UCLA. So basically before the Octeotide PET scan, the referring physician had to fill out the pre-scan questionnaire and pointing out what he thinks is the status of the patient and what he thinks he might do now without the information of the Octeotide. And then the Octeotide is performed, and then after that, at certain time points, it's again the referring physician gets a questionnaire, and then based on the findings now, so based on what the Octeotide scan showed, now he gives again his consideration, what is the status of the patient and what he wants to do now. And if we look on the data for this analysis, you see that for patients who had a suspicion that they had metastatic disease, so that the disease unfortunately is not related to an organ, for example the pancreas, but for patients in whom the disease has spread out, the impact of Octeotide scan was totally evident in 1/4 of the patients. So meaning in 10 patients, the suspicion of disease, this suspicion of the distribution of disease has increased, because we found on PET some things which have not been known before from other imaging procedures. good for the patient that also in some of them there was a decreased suspicion, because sometimes you can get findings which you don't know how to take them, whether this is just, for example, in the liver, it's a benign lesion, or whether it can also be like a liver metastasis from neuroendocrine tumor. So in some patients also the suspicion for disease was decreased, decreased, and in the other patients there were basically no change. If you look then not only on the suspicion of disease, but also on the concrete change of management, then you see, if you group these multiple subgroups to 4 major groups, that in 1/4 of the patients the dotatate can say, okay, for this and this reason it does not make sense to do an operation. This was in 1/4 of patients. Then in another 1/4 of patients, the dotatate can brought up findings or decreased suspicion of other findings, so that the patient finally could then have an operation. Or patients were taken from treatment to watch and wait, because the scan brought up that there is a relatively stable disease. And also the other way around, where the physician in the beginning thought it might be stable disease, but unfortunately it was not completely stable. So these patients had to be moved to treatment. So this is an exemplary case of this. This is a patient with a high-grade tumor, and high-grade tumor means that you have an so that was the clinical suspicion that it's a high-grade tumor, and there was a high-grade suspicion of metastatic disease. Given the fact that the physician was thinking that it's in high-grade tumors, and high-grade tumors often do not show a good somatostatin receptor expression, he thought, okay, this patient unfortunately has to go to chemotherapy, but happily the dotatate scan showed very intense uptake in some of the lesions you see here, and so this patient could be offered a radionuclide treatment, which I will show in a minute. So the dotatate PET agent, also called Netspot, how are we currently? I guess some of you know that FDA in June approved a dotatate called Netspot as a new diagnostic agent for neuroendocrine tumor imaging. Currently, the reimbursement is not in place. It should be in place beginning of next year. I just heard this some minutes ago. So the institutions who perform dotatate PET imaging under certain INDs, or an investigation new drug application study, still most likely will do this to the time when the reimbursement is finally taken in place. So besides the imaging agent, there are also important developments concerning radionuclide therapy. I explained in the beginning that you can use the ligand and bind it also to the therapeutic agent, for example, lutetium-177, and then do internal radiation treatment, because this agent binds to the tumor cells and does an internal radiation of the tumor cells. And how does this work, or is this a completely new concept? It is fortunately not a completely new concept. So nuclear medicine has made very good experience also on applying this kind of concept in other disease, for example, which is only very rarely, but then it can be very effective performed, is a treatment in non-Hodgkin's lymphoma, which is a disease of lymph nodes, so meaning that you have these are patients who basically have lymph node cancer. It is now very increasingly, especially in Europe, also used for prostate cancer imaging, where you also have a specific target and a key to access this target, which you then can on which then you can bind a radioactive agent. And finally, there is an now commercial available product, the so-called Lutathera, which is available by AAA. And this has recently been proven in a multi-center study that it has a positive effect on outcome of the patient, which I will show in a few slides. And this is an agent, as I've shown before, where the somatostatin receptor 2 is approached with a lutetium-177 beta emitter. So the trial who was investigating the use of this therapeutic agent on patients with neuroendocrine tumor is the so-called Metadrill, and it was a trial which evaluated the efficacy, so the outcome of the patient, and the safety of this treatment combined with an SSA, and comparing this with the standard treatment or a high dose treatment of Octeotide, so the sandostatin treatment. And these were all patients in which there was an inoperable disease, and then prior scan, for example an Octeotide scan or a PET scan, has shown that the somatostatin receptor is highly expressed. This was, and I think this is important also with regard to how reliable the data is, and this was certainly also a very big or important point to get this drug on the edge of approval, which it is now. It was an international trial, it was not a local trial, it was a multi-center trial, and it was this randomized design. So randomized basically means you have two groups. So there was one group who got the hot medications or the radioactive medication plus sandostatin, and on the other hand there was the patient group who were treated with the high dose Octeotide, so also another sandostatin analog. And both the patients and the physicians, they did not know which they got, or the physician did not know what they were giving to the patient. So this is the most important result from this study. This is a so-called progression-free survival. And what does it mean? It means that the time was measured until on, for example, an CT or an MRI image, it was evident that the tumors were getting bigger. And if you look now on the green, this is the curve for the radioactive treatment versus the black or dark blue, which is the curve for the Octeotide treatment. You see that every step down is an event, meaning that in one patient or in several patients progression has been found, unfortunately. But if you look on the green steps compared to the black or dark blue steps, you see these are going down considerably slower than the other curve, and this indicates that the progression-free survival is considerably higher, so that the patient has a positive effect because the growth of the tumor was more hampered or more slowed down by the radioactive treatment compared to the Octeotide treatment. Also, what is important, as I've pointed out, is the toxicity of or the safety of a new drug, and here it was basically not that big difference. So-called serious events occurred in the same percentage in the group of the patients treated with one or the other medication. What is relatively typical, you see here, is if you get the Lutathera or the lutetium dotatate treatment, is vomiting, which you don't usually get in the Octeotide long-acting somatostatin analogon. However, this vomiting is often not related to the treatment itself. It's related to the preparation the patient has to undergo, and the preparation you can see here. Wait, let me just now. Okay, here. The preparation consists of an amino acid infusion which the patient gets over 4 hours, and this contains all the amino acid which are available, and this usually can lead in a considerable number of patients to nausea or bad feeling or even to throwing up, and this is the reason why in the Lutathera compared to the other group this incidence is so much higher, so 7 versus this 0%. And also one important thing which we as physicians have to take into account, that with radionuclide treatment you can also have negative effect on the bone marrow, so-called, for example, so-called lymphopenia, which means that a certain type of the blood cells, the so-called lymphocytes, they go down. This is also nothing which is known from Octeotide. Fortunately, this is only temporarily, so usually after 6 weeks, then the lymphocytes they reach their prior level and go up. One additional point which is very important to take into consideration is the possible toxicity to the is the possible toxicity to the kidneys, because as I've explained you in the beginning, there is a very high uptake of the kidneys in the diagnostic agent, so this means that also the activity can go to the kidney and can potentially harm the kidney, as this is a beta emitter, so the kidney gets irradiation. Fortunately, at least in this trial, when you use lutetium, no severe kidney changes occurred. So you see the creatinine level, which is basically the level for your kidney function, was not impaired in the patient who got the hot medications. If you go a little bit more in the past, especially if you go to Europe, because this treatment there has been performed in Europe much longer than here, physicians in the past were also treating with, for example, yttrium, and here the rate of kidney toxicity is a little bit higher. But I think the agent which is going to be approved is the agent with the lutetium, so here the risk for kidney failure is very minimal. So as I've just pointed out, yttrium was used now more than, or very exactly 20 years ago. It's already this treatment of neuroendocrine tumors using a beta emitter as internal radiation treatment is more or less standard of care in Europe, and it's implemented in a lot of guidelines in the different European society, but just as there were lack of randomized clinical trials, there were only rare possibilities to get this treatment in the US, but this is now changing to this Metadrill, which I've introduced to you. So if somebody is scheduled for potential therapy, first you have to get sure that the target is expressed high enough, as in this case. We have to do blood tests and kidney tests. As I've told you, kidney function potentially can be impaired, and also the blood tests have to be taken into consideration. And then the patient is consented, and the patient gets information about the treatment itself. And the information mainly basis on the principle I've introduced you, so this principle of having a ligand with a linker on the left side, which is the cold part of the substance, and the so-called hot, or the radionuclide part. You see, patients often ask how much of this agent do I get. So basically, you get a very little dose of the agent itself. So the amount of agent which is administered to the patient is 1,000 times lower than the somatostatin receptor expression or the somatostatin receptor concentration in the tumor tissue. So that means that the complete binding of all receptors is not possible, and this is also the reason why pharmacological side effects are very, very unlikely. On the other hand, we have a very low concentration of the peptide itself, but we have a very high radioactive activity of the lutetium. And for example, if you look in data how much radiation we can get with this lutetium to the tumor cells, the radiation is often measured in so-called gray, so this is the strength of radiation. So in mean, up to 14 grays can be applied to tumor lesions giving this agent. And if you compare this, for example, to doses known from external radiation therapy, so they are considerably beyond this number. How does it work in the US? In the US, it's an outpatient procedure. In Germany, when I was there, when we did it, we had to do it as an inpatient because radiation protection rules are very strict in Germany. Fortunately, they're not so strict in the United States, so this can be done as an outpatient procedure. It just means that the patient has to stay around 8 hours in our department, and several things are done, which I've already explained you, getting the patient some amino acid infusion for kidney protection, and then administrating the radioactive drug, and then in the end also some blood tests are drawn to look on certain parameters, for example, the potassium level. If possible, also so-called post-therapeutic images are required, so the patient gets under the camera the day after the treatment, and he does not need an additional radioactive shot because he still has radioactivity in his body, which is having effect on the tumor cells, and which also can be measured from outside, as you see in this patient, where you see a very nice uptake in this tumor lesion. And this is as quality control always very interesting to see whether the agent really has hit the target, and to make an rough estimation how good the tumor effect will be. This is, for example, the patient I showed you before with this one large and one little lesion in the liver, and this is after 4 administration of the radioactive agent, where you can see that especially the large liver now is nearly has gone away, and this little lesion also got a little bit smaller. So PRT, when is it available? It is the short answer. It is now, but unfortunately only currently for some patients. And the reason is, so the Lutathera agent is shortly before being approved from FDA. We treated 5 patients since the start of a so-called early access program. So an early access program means that some patients can get a radioactive agent which is not finally approved, but everything looks that the approval will take place very shortly. And under this so-called expanded access program, we get the medication for free by AAA, and the patient had just to take care for other logistical costs, but the medication itself is too free. I hope that FDA approval will take place end of this year, and potentially also reimbursement. So then, with beginning of next year, we could potentially offer this treatment to a broader range of patients. We have granted 7 spots for early access program now. Unfortunately, we have already filled all spots. Currently, we are treating this patient, but unfortunately, we are not, at least at this point now, we are not allowed to get additional patients. We try to get additional patients. I hope it works, but we will see. Okay, so I'm already finished with my talk. I would shortly introduce the UCLA team for neuroendocrine imaging and treatment. This is especially on the left side, the guys from nuclear medicine, so Johannes Janin, the head of nuclear medicine, then Ken Herman, who brought a lot of these things to UCLA, and he was really working very hard to get this into clinical practice. He He was a former colleague of mine when I was in Munich, so I worked together with Ken already 5 years ago when he was in Munich, and then he moved to UCLA, and there's also Andrew Kwon and Martin Auerbach, two physicians who are responsible, and another visiting assistant professor, Wolfgang Fendler, from the other university hospital from Munich, and a lot of other people from clinical disciplines who are a part of this NET team. Okay, thank you very much.
Thank you, Dr. Eiber. We are going to do a quick Q&A.
You mentioned having 2 scans over a time period apart so you can see if there's progression. Now, is the calibration of the scans pretty accurate so that it's a meaningful difference you can see?
This is probably a question I should answer, I guess. So this is a very good question. So one thing which is currently being done is the standardization of all scanners, so that there are very, very narrow ranges of, let's say, errors or mismatches, but nevertheless the SUV, so the standardized uptake value, is already a quantitative value, which is, not as exact as it could be, because this harmonization program process is just started, but it is known that plus minus 20%, if there is an increase of 20 or a decrease of 20%, then we call it a real progression or a real regression. So these are certainly the range in which you say if a lesion increases an uptake of 10%, we would not call this clear and progression. The threshold is 20% plus or 20% minus. On the other hand, if you have a new lesion, so this is always called a progression. You can have new lesion with response of old lesion, but new lesion often means, by definition, if you, for example, go to RECIST or PERSIST criteria, a new lesion always means a progression.
How do you determine how many treatments you need?
So I think so the protocol under which this study was performed, the Metadrill, and also like the clinical routine protocol patients are treated in Europe, is that patients get 4 cycles of this treatment. The interval between the cycles is each 8 weeks, so a period of 4 by 8 weeks. And then after 4 cycles, usually the patient gets a kind of imaging study and then looking how good was the effect. So I don't know how this will then finally end in clinical routine in the US, because I think the Metadrill was designed for 4 cycles, so I'm not sure how will be the final approval, or whether it will be like 5 cycles in the prescription, but then it is possible to do more cycles as an individual decisions. In Europe, we do often vary more than 4 cycles. So we do a standard of 4 cycles. If we see good response, we do then 2 cycles. I mean when I was in Munich. But we have also treated patients with up to over 20 cycles. So it depends, whether you have still good target expression.
On those cycles, based on the European information you have, when do you start seeing an impact on the actual tumors after which cycle, what percentage of each cycle?
So it's not worth to do imaging after the first cycle. You can, if you do PET imaging, then you can see effect sometimes after 2 cycles. You definitely see effect, if the patient response is always the necessity. You see always, for a good patient, response on after 4 cycles, and after 4 cycles you can also see response in morphological imaging, so meaning in CT, that in CT the size, for example, for lymph node gets smaller, but often the morphological, so the CT size changes are a little bit later than the functional, so meaning the changes in the PET. But it's not worth to do imaging before 2, and we would even not recommend to do it before the 4th cycle. Only like sometimes, if there's a high clinical evidence of progressive disease because the patient has new symptoms, then it would make sense, but not as a routine.
In the PRRT, the targeted radiation, does that, have you seen any effects of that targeted radiation on non-tumor cells that you don't want to kill?
So there is definitely some effects on the kidney, because as I've shown, the kidneys are very hot, so the agent goes to the kidney. So the lutetium does not seem to be this big problem, at least in patients who have normal kidney functions. They tolerate well the 4 cycles. It is a little bit different for the yttrium, or at least when it was done in the old days without the amino acid protection. Then the patient could also get severe kidney failures. But since the lutetium treatment and since the amino acids are applied for kidney protections, we don't see this anymore with a high incidence. Sometimes we see also, as I've spoken about, this slight decrease of bone marrow function, but usually after 8 weeks, bone marrow function is still at the initial level. But you can see a decrease, and a small decrease in the meanwhile.
I have a request to ask these questions. The question is, can the primary have a good uptake while meds do not? Is this usual? Can uptake in liver change over time if there is progression?
So this is a very good question. So I would say in the beginning, so when a patient is primarily diagnosed, it's usually that the primary tumor and the metastasis have the same level of expression. Unfortunately, with time is going by, so let's say after many years, sometimes we see that the primary tumor, which then in many cases has already been taken out, so only like other lesions are left, but gradually sometimes we can see that unfortunately the metastasis can lose their target expression, so the somatostatin receptor expression goes down. This sometimes we can see, but not so often. And it would not be typical that you have the primary tumor in place, so so if you have now just a diagnosis, and for example the patient has already some metastasis elsewhere, that you have different expression of the primary tumor and the other lesion. This is not very typical. But gradually with time, sometimes you can see it, but fortunately not very often.
So I had a GA68 done at UCLA, and it showed lesions in certain areas, but they weren't designated as NETs. So those are something different.
Yeah,
is that correct?
okay.
Will it pick up other things as well as, let's say, kidney stones or gallstones? Or will it be just specific for NETs?
No, it is relatively specific, but nothing is 100% specific. Because sometimes you can see thyroid nodules which can be hot, which are very unlikely to be related to neuroendocrine tumors. Or you can see sometimes unspecific uptake in the bone, for example, in older patients who have a lot of degenerative changes in the bone. If you have, I think you were asking in the beginning, lesions in the lungs. So if we see them bright, so hot in the PET, then it's very likely to be from the neuroendocrine tumor, but it can also be the case that these lesions you are talking about have not been seen in the PET, but seen in the CT part of the examination. And for example, in the lung, you often see very tiny nodules, and this can be also some old scars after pneumonia, and they can take it up very little, but are very unlikely to be related to the neuroendocrine tumor. So it depends whether you see it in a CT or in a PET, and how bright they are in the PET.
Does I'm not clear on the process, does it attack all of the tumors inside an organ equally, or does it go, how do you adjust for the primary largest tumor, or does it not work that way?
So it addresses the tumor based on the expression level of the target. So what sometimes can be seen that some lesions have a very high uptake, and other lesions only moderate uptake. So the effect is presumably higher on the hot lesions than on only the moderate hot lesions, because they get a higher amount of binding, so a higher amount of radiation. But it is not possible to make a direct, what has been tried in the past to compare the dose to a single lesion with the effect on a single lesion, but there is no direct proportion. There is a a rough proportion, but not a very a strict direct proportion, because probably biology of the tumor is more than just the somatostatin receptor expression.
We actually have Ayala from AAA here. She can answer questions about insurance, but again, please keep them general questions about insurance, not personalized. So Ayala, you please come up. So we have the, who do we have on the phone?
Hi everyone, I'm Ayala Luria and I'm the Medical Science Liaison for AAA, Advanced Accelerator Applications. Thank you for your call, for your talk, sorry. On my call here, I have my colleagues. Hugh Jones, he is the VP of Marketing and Sales. And then I have Roger and Ken, the managers for market access. So any questions that you have about insurance and reimbursement or anything like that, I cannot answer. Scientific question, I believe that Dr. Eiber will be able to answer.
I thought I heard somewhere that September 15th or something, there may be reimbursement available at UCLA for Medicare for GA68 scan, but I think I heard doctor saying that it may not be until next year, so I just want to get clarification.
Let me refer this question to the group. Roger, Ken, there's a question from the audience regarding announcement September 15th that it will be reimbursed. UCLA, you said? UCLA reimbursement will be in place. Do you have any information about that?
This is Roger Stavros. Hi, everyone. I'm not really sure what this announcement regards to specifically, but I can share with you a general update that may shed some light a little bit. So Kenny is also on the phone. Kenny Stranigan, he is the regional access manager from AAA. He is responsible for the West Coast region, and obviously including California, where you guys are located. And we've been in touch with a lot of payers, both public and private payers. We've reached out to the Medicare MACs, the Medicare Administrative Contractors. We shared the information about gallium Octeotide, and some of them are still evaluating their decision process as far as coverage. But one thing that I want to make sure that we're clear on is how the MACs, the Medicare MACs, as well as private payers, they separate the decision between coverage and reimbursement. So the first step is to get coverage, and the second step is work out the details around what it would take to get the reimbursement in place. And that's a lot of this is being worked on right now. If you can share a little bit more about about the September 15th announcement that you're referring to specifically, maybe we can help you shed some light onto that a little bit.
I think what Jeanette's referring to is I saw it also, and I can't remember where it came from, but somewhere it was posted that Medicare would be covering, that we would have Medicare, that Medicare was going to be approving it, like whatever that date was, September 15th.
As far as the West Coast, Kenny's been in touch with Noridian, which is the Medicare MAC for the West Coast, and we're in touch with them. We'll provide them information, and we've addressed any questions they may have. And at this point, it's just a matter of us waiting to hear decisions. So maybe I've heard through the grapevine that maybe that's in regards to them, but that could be that. It could be it. But either way, I mean, the 15th is 2 days away from now, so hopefully it will be positive news for everyone.
If we've had the scan and we're scheduled for a PRT before the end of the year, is there a chance that might be reimbursed after the December date?
So the answer to the second part of the question, actually, Ayala, is much easier. There will be no reimbursement for PRT until the FDA approves it. The only way to get PRT before the FDA approves it is through the Expanded Access Compassionate Use Program, which I'm not sure if the gentleman asking the question is referring to that or something else. But obviously, an expanded access protocol is a is a medical question. So you Ayala and Val are perfectly able to answer that. But there would be no commercial reimbursement for PRT until the FDA has approved it. Absolutely not.
I can answer that, but the
And quickly to answer the first question, at this point, since PRT is not FDA-approved product, there is the payers, both public and private, do not recognize any relationship between the two products. So the question is really hard to answer because it wouldn't make a patient eligible to receive PRT in any way. And it's just at this point, from a payer standpoint, just because they do not recognize that PRT since it's not FDA-approved product. Once we get into the post-FDA approval environment, whenever the FDA hopefully approves PRT, then one of the eligibility criteria for receiving PRT will be a somatostatin receptor avid disease, which is easily identifiable and easily measured using a gallium scan. So that will be the future relationship between the two. If a patient is considered by their physician to be PRT eligible, they will need to have hopefully a gallium, but also an ultrasound would do this as well. They need to show that they have somatostatin avid disease in order for the PRT to work. So that will be something that comes into play later on down the line.
thank you.
So the question would really be, once Medicare approves it, will it be easier to go retroactive after your commercial insurance for reimbursement?
So we get into a minefield here because it's a case by case, and it's really hard to answer this question specifically. But in generality, private payers, they make decisions independently from Medicare. So the coverage decision, it will be dependent, even as well as reimbursement. As I mentioned earlier, there are two things, and they're both separate. Coverage is one decision. Reimbursement it's a completely separate process, and there are a lot of steps that has to be taken to get reimbursement done. And just very briefly, from a Medicare perspective, as a product, as a radiopharmaceutical product, like Netspot, we would need to have a pass-through code, which is a mechanism to get the product reimbursed outside of the PET imaging procedure. And AAA submitted the application to CMS earlier in the month, and this is a process that we have to take with CMS, and CMS have to issue that pass-through code specific to the product. And once that's done, it will be communicated to the individual, to the different MACs, and it's going to be made available, published to everyone. So having said that, the MAC's decisions, any decisions comes from the MAC prior to pass-through, it's independent from a reimbursement process. So a MAC can decide a product is covered, but the reimbursement may be different or quote-unquote unfavorable in one way or shape or form, and that's where other things will have to happen from a reimbursement standpoint.
Thank you.
Okay, this is going to be the last question, and we'll shut off the video camera, and we'll go into the more personal questions.
So my understanding is it on? Well, my understanding is that that gallium has more affinity to the receptors. But in some of the pictures that you showed, there were some lesions that showed in Octeo scan that didn't show in gallium scan. Why is that? I thought there was more affinity, or is it that it attaches to different receptors, or?
So your question is related just on imaging, not comparing imaging and therapy. Is that correct? You are want me to
compare-
answer differences between Dotatate scan and the Octeotide scan?
Yes.
Okay.
Yes.
So I don't know exactly to which images you're referring, because I thought I've just shown one Octeotide image, but nevertheless, so
Maybe it was Indian.
yeah, the one indium indium image I've shown. So the key to the lock, so the ligand, is the same, having the Dotatate or the Octeotide, so the indium Octeotide. So I agree that there are some, so the values for like their affinity are not the same, but the values for the gallium agent are considered to be higher. And in addition to that, it's also that the spatial resolution of a PET camera is higher than a SPECT camera or only doing plain scintigraphy. So basically it would be very unlikely that you see lesions on an Octeotide which you not see on a Dotatate PET scan. But nothing can be excluded completely, but it would be very unlikely based on like the affinity of the agent and based on like the technical differences between PET and scintigraphy.